ये चार्ट नहीं आ रहा महेंद्र, चार्ट. Okay. So good evening everyone. Sorry because of some network issue. I have to change the studio. So I guess we are connected now. I'm going to start. Already we have wasted 10-15 minutes. So, but I cannot see the chart, so I'll wait for 2 minutes for the chart to appear. Mahinder, beta chart dekh lo. Yeah, now it's good, very good. So now I can see. So yeah, we had, I was actually started my lecture from a new studio, which has recently been constructed here. But there's some network issues, so we have changed the studio. I think everything is fine now. Chalo, let's start quickly. So question number 1 says, achalasia is characterized by. So what is basically achalasia? So good evening all of you. Right, you see. Achalasia basically hai kya? In achalasia, this is the esophagus. So in lower esophagus, AUERBACH, Orbeck plexus, which are also called Mindtrick plexus, they are absent. Remember, just 2 lines. Orbeck plexus are absent or Mindtrick both are same, and only inhibitory fibers are absent. Meissner's ganglion are not involved. So another ganglion called MEISSNER, Meissner's ganglion are not involved. So you see, in achalasia, only inhibitory fibers of Orbeck plexus are involved. Meissner's are not involved, and complete Orbeck plexus are not absent. Only inhibitory fibers are absent. Okay. What are the salient features we need to know? Achalasia is characterized by absence of inhibitory fiber of Orbeck plexus. Point number 1. Young middle age. Normally, age is not children, not old. Young middle age, you can say around 15 to 50. 20s and 30s more often. Either you can say male female equal, or you can say slightly more common in female. Never say more common in male. So it's usually equal, but slightly more common in female. Another important point, dysphagia starts with liquid. In all other conditions, dysphagia starts with solid. Here dysphagia starts with liquid. And there are 3 types of achalasia. Primary, the most common type, abscess of ganglion. Secondary, caused by Chagas disease, infection, and pseudoachalasia caused by cancer. This is the question also of old NEET question. Pseudoachalasia, cancer, infection, Chagas disease, secondary, and primary absence of ganglion. Now, triple A syndrome, there are 3 A. First is alacrimia. Second is achalasia. And third is ACTH resistant adrenocortical insufficiency. So patient presents like Addison's disease. I think it will be hidden by me, so I'll go a little sideways. So ACTH resistant adrenocortical insufficiency, that is triple A syndrome. Achalasia, alacrimia, and ACTH resistant adrenocortical insufficiency. Cancer risk is more, but this is a very important point. Achalasia involves the lower segment. Lower segment cancer should be adenocarcinoma, but in achalasia cancer in the normal this is the part which is having absence of ganglion. Cancer develops in this area. So not in the achalasia area, cancer develops in the area from where it has come by. Cancer develops in the area which is normal. So we have squamous cell cancer. Manometry is the gold standard test, although barium gives bird beak sign or rat tail sign. Treatment is Heller's myotomy or POEM, per oral endoscopic myotomy. Most common site for cancer is the dilated middle 1/3 of cancer, or the proximal part, not the distal part, and the type is squamous cell cancer. This is a bird beak sign, a very important texture for you, very frequently asked. And this is a rat tail sign which you get in 2 conditions, achalasia and cancer both. In cancer, the edges are serrated and irregular. Let me magnify this. So irregular edges with filling defect, while in achalasia it is absolutely smooth. So both can have rat tail sign, but in achalasia the rat tail will be smooth, and in cancer the rat tail will be irregular and serrated. Chicago classification I'll tell you, but we don't have too much time, so I'll just take 2 minutes and I'll tell you what they ask and what you need to know. Dekho, only remember 3 lines. In manometry, what you get in achalasia? 2 finding. Number 1, there is absence of relaxation. So there is non-relaxation of lower esophageal sphincter. So LES is not relaxing. That is the point number 1. Point number 2, absence of peristalsis. So peristalsis should be absent. I'll repeat. There are 3 types of achalasia in manometry Chicago classification. All 3 will have these 2 findings. LES fails to relax and absence of peristalsis in the esophagus. Now, the third point will differentiate between 1, 2 and 3 in Chicago. 1, the pressure of the peristalsis is either low or normal. In 2, the pressure is high. In 3, the pressure is high. In 2, whole esophagus having high pressure called PEP, pan-esophageal pressurization, while only lower part having high pressure called distal spastic contraction. I will repeat what I said. If you know, it's revision, it's good. If you do not know, then probably will not follow what I'm saying because it's a little complex. So in Chicago classification, there are 3 types. All 3 have 2 common features. 1 is LES not relaxing. Number 2, absence of peristalsis. The third finding will differentiate. First is low or normal pressure peristalsis is type 1. Type 2, the whole esophagus having high pressure called PEP, pan-esophageal pressurization. And type 3, only distal part having high pressure called distal spastic contraction. Okay. So these are the 3 types. You have 1 or 2 questions, although it is not very important. This is very important. Remember this X-ray. Remember this rat tail sign. This is the Hiller's myotomy. From where to where we cut? We cut lower esophagus sphincter. But look at the screen. My incision must go towards the fundus of the stomach, at least 2 to 3 centimeters. We do have some fiber here in the fundus. They are not part of the sphincter. They are called collar sling fiber or Helvetius collar. Helvetius. Helvetius collar. This needs to be cut. If I do not cut this fiber, then the results are not very good. So my incision doesn't only cut the sphincter, it extends about 2 to 3 centimeters towards the fundus of the stomach, cutting the Helvetius collar or collar sling fiber. So this is the myotomy, Hiller's myotomy, and this is POEM, per oral endoscopic myotomy, where you go from the oral cavity, go from the mucosa, make a submucosal tunnel, cut the mucosa and close the defect. So POEM is another surgery called per oral endoscopic myotomy that's done for achalasia. Okay. Now question number, and this is another X-ray not related to achalasia but very commonly asked MCQ. This image they show और फिर पूछते हैं कि what is this? This is the corkscrew appearance of diffuse esophageal spasm. So diffuse esophageal spasm showing corkscrew appearance. Okay, this just a image based question. They don't ask about DS in detail, only they show the image और पूछते क्या है ये. This is corkscrew appearance in DS. If I don't cut these fiber, then the results won't be as good. These fiber also needs to be cut for the proper complete surgery. Okay. Now question number 2. What is the main etiology of the late dumping syndrome? Yes, fundoplication, Aishwarya, is performed to prevent reflux. Heller's myotomy very often leads to reflux. So what you are looking at here, this is a door fundoplication. So fundoplication is not to treat achalasia, it is to prevent the reflux problem of myotomy. So this is the question number 2. Late dumping syndrome is caused by hypoglycemia. Let me explain what happens in dumping. Suppose I have done a Billroth 1 gastrectomy, you can see, or I have done a Billroth 2 gastrectomy like this, or I have done a Roux-en-Y. You can see in all 3 conditions, the food is directly going from stomach to duodenum or jejunum without any sphincter. First image is Billroth 1, second is Billroth 2, third is Roux-en-Y. And what happens now? The hyperosmolar food rapidly enters into the small intestine. No sphincter. Whatever you eat will immediately go here, here, or here. So the reason of early dumping is the food which should remain in the stomach for at least 2 to 6 hours rapidly goes into the small intestine. So hypoosmolar food going into small intestine, this is how dumping starts. Well, the feature will be, and it is seen within 10 to 20 minutes after meals. Feature is diarrhea, osmotic diarrhea, tachycardia, thirst, rise in hematocrit, and abdominal and vasomotor changes like bloating, like nausea, like pain, dizziness, and flushing, etc. So these are the features of early dumping which happens within 10 to 20 minutes after meal. Why it happens? Rapid exposure of a small intestine to hyperosmolar food. Now what happens? The food gets absorbed rapidly and patient goes into hyperglycemia. So in about 30 minutes time, there is hyperglycemia, the sugar gets absorbed, and another 30 minutes, 1 to 3 hours after meal, the GLP-1 gets stimulated, which stimulates insulin, that causes hypoglycemia. This is called late dumping. Tremors, sweating, palpitation, emptiness. Patient may become unconscious, may have conversion due to severe hypoglycemia. So 1 to 3 hours after meal, GLP-1 glucagon-like peptide 1 due to hyperglycemia stimulated, and that leads to reactive hypoglycemia. That's called late dumping syndrome. So early dumping is due to hyperosmolar food rapidly going to small intestine, late dumping due to hypoglycemia. This is the reason of late dumping syndrome. This we have discussed, I discussed in detail in our regular batch. So this is basically early dumping seen within 10 to 30 minutes, and patient develops features of vasomotor changes, sweating, flushing, bloating, diarrhea, and late dumping 2 to 3 hours after meal. That is due to hypoglycemia. So early dumping is bloating, sweating, dizziness, flushing, etc. Late dumping, feature of emptiness, hunger, sweating, and hypoglycemia feature. This is wrong actually. We don't get this after sleeve gastrectomy. We get usually after Roux-en-Y or Billroth 1. See another question. A 50-year-old patient complains of hematemesis after retching and vomiting. See, first retching or vomiting, generally they say binge drinking. Very often you'll find this word in the question. So patient having binge drinking, he had vomiting followed by hematemesis. Endoscopy showed a linear cut here. There is no active bleeding. No active bleeding. First of all, I'd like to know from you, what is the diagnosis here? After binge alcohol, patient had vomiting, then he had hematemesis. Very good. The diagnosis is Mallory-Weiss tear. And this is, the bleeding is by the left gastric artery. And Mallory-Weiss tear is known to be self-limiting in more than 95% cases. So the answer is just expectant management, because there's no active bleeding. The bleeding will stop by itself. If the bleeding is continuing, then you can go for sclerotherapy, endoscopic sclerotherapy, but only when the bleeding continues. As you can see, there's no fresh bleeding here in this area. So answer is expectant management. And these are two more images of Mallory-Weiss tear in the right side. Where the tear is here. Tear is here, where I'm placing the red mark here. Longitudinal tear on the right cardia below GE junction. What other question you get in upper GI bleed? So a 35-year-old male presents with 2 episodes of hematemesis. He gives a history of upper abdominal pain lasting for last few months. He gets up early morning with hunger pain, and the pain is relieved by meals. What is the diagnosis and what we should do here? So my question is, upper abdominal pain relieved by, no Kamraj, we don't do angioembolization, we do sclerotherapy, endoscopic sclerotherapy. Angioembolization has no role in Mallory-Weiss tear. Okay, Kamraj? Either bleeding will stop by itself, so we go for expectant management. But if the bleeding continues, you go for sclerotherapy, not embolization. So this is a question on duodenal ulcer. All of you are correct. What about second question? A 45-year-old male with chronic liver disease having mild ascites and spider nevi. So what is the cause of hematemesis here in this question? Second question, obviously liver disease. So here the cause will be varices. So I guess you can make out the difference in 3 cases of hematemesis. If the question says after binge of alcohol and patient having hematemesis, patient having vomiting followed by hematemesis, this is Mallory-Weiss tear, a tear at the right cardia, only managed conservatively, usually or rarely sclerotherapy. Duodenal ulcer? Yeah, that's correct. The gastric ulcer which bleeds is Johnson type 4, the artery is left gastric. So let's see here. In the first question, the diagnosis said duodenal ulcer. In second question, diagnosis of varices is very easy. Which artery bleeds in gastric ulcer? It is the left gastric artery. Which artery bleeds in duodenal ulcer? Gastroduodenal artery. So left gastric artery for gastric ulcer and gastroduodenal artery for duodenal. What is the first drug you give? The first drug is Boerhaave is a totally different condition, bachche. I saw your question earlier, but it's so weird that Boerhaave presents with pain, beta. यहाँ पे दर्द होता है खाने के बाद, pain, not bleeding, and causes metastasinitis and perforation and death. So Boerhaave is totally different condition. You can see my video on NEET app. Boerhaave is a major topic, takes about 45 minutes. It's a tear in the lower esophagus on the left side, through and through tear. It presents with pain and pneumomediastinum. And Mallory-Weiss presents with bleeding. So first drug is IV pantoprazole. And what investigation? Endoscopy. and endoscopy should be done within 24 hours. Don't delay endoscopy beyond 24 hours. Treatment, if it is duodenal ulcer, treatment is sclerotherapy. If it is varices, treatment is band ligation. For varices, I will add one more drug, octreotide, only for varices, not for ulcer. Number 2, terlipressin. Terlipressin is most effective for varices, but word of caution. Octreotide and terlipressin are for varices, not for ulcer. For ulcer, treatment is only endoscopic sclerotherapy. Don't say banding for ulcer. Banding for varices, sclerotherapy for ulcer. Okay? So, this is the artery which bleeds in gastric ulcer. Which artery? Left gastric artery. This is the artery which bleeds in duodenal ulcer. Which artery? Gastroduodenal artery. Now, Graham's patch is not for bleeding. Graham's patch is for perforation. That is my next question. In all cases of hematemesis, you have to go for, and first give PPI and go for endoscopy. In case you find a varices, you do band ligation, and you find a ulcer, you do sclerotherapy. Of course, octreotide or terlipressin can be given if you already know the diagnosis that this is varices. Drug of choice according to American board is octreotide, because terlipressin is not approved there. But rest everywhere, including India, terlipressin can be given. So I guess this particular, I'll repeat, a question on upper GI bleed, you can differentiate how? By simple history examination in some points. Patient had binge of alcohol, then vomiting followed by hematemesis, tear on the right cardia of the stomach. This is Mallory-Weiss tear, generally managed conservatively. Rarely, if bleeding continues, go for sclerotherapy. If patient is young, he is executive, he is a known case of duodenal ulcer, or the pains are relieved by meals, or he is on prolonged NSAID, etc. He is taking NSAID for bone pain, then probably it's a duodenal ulcer. And he is a known case of liver disease, it's varices. So you can differentiate between the three, okay? And first thing should be IV pantoprazole followed by endoscopy. If you know that this is varices, then you can give octreotide or terlipressin, both can be given. Terlipressin is more effective, but can cause mesenteric ischemia. Then in endoscopy, it's varices, go for band ligation, or rarely sclerotherapy, but band ligation better. If it's general ulcer, go for sclerotherapy. Okay, very simple, 4 lines, 5 lines. Now, see this question. A 4-week-old child brought to emergency with 2 days history of projectile non-bilious vomiting. 2 things are important. 4-week male. And I will tell you the treatment of ulcer after this. After this, I'll tell you treatment, because I think many of you are confused. Someone is saying omental patch. Omental patch is for perforation, bache, not for bleeding. It means you are confused. So I'll explain this after. Let me finish this question, then I'll tell you. So it's a non-bilious vomiting and a olive-shaped lump. So I'm sure all of you can make the diagnosis. It is CHPS, congenital hypertrophic pyloric stenosis, or IHPS, infantile hypertrophic pyloric stenosis. So this patient is not treated immediately because you have to correct the dehydration and acid-base imbalance. So A is wrong. This is considered a non-surgical emergency. So you never go for immediate surgery. First correct the dehydration, acid-base imbalance, then go for surgery. You do get hypochloremic, hypokalemic alkalosis plus paradoxical aciduria. Hypochloremic, hypokalemic alkalosis plus paradoxical aciduria, and the reason of aciduria is aldosterone. N/2 saline with KCl should be given, that is the fluid of choice, and Ramstead pyloromyotomy is the treatment of choice. All 4 are right, all 3 B, C, D are right, A is wrong. Let us understand the salient feature of CHPS. Number 1, more common in male, 4:1 ratio. Number 2, projectile non-bilious vomiting between 2 and 8 weeks. Number 3, stomach is always empty and child is always hungry. Unlike adults, where outlet obstruction stomach will be associated with retained food in the stomach, distended stomach, here the stomach is empty and child is hungry. No retained food in the stomach. This is MCQ, remember this. Olive-shaped lump, this is the olive-shaped lump here. In the epigastrium, become more prominent after meal, and left to right peristalsis, left to right visible peristalsis. No polyhydramnios, and ultrasound is the investigation of choice. What you get in ultrasound? The length of pylorus, this red line is the length and the blue line is the thickness. So length more than 16 millimeter and thickness more than 4 millimeter is diagnostic, plus the sign, target sign, enteral sign, cervix sign you get. Barium, you can see the string sign and the mushroom sign. So barium will show string sign. Aldosterone, I'm not wearing my specs, so I cannot read the name. Aldosterone, Arushi, is because of hyponatremia and dehydration. They stimulate the aldosterone. Then aldosterone absorbs sodium and excrete hydrogen. That leads to aciduria. And you are correct, Shimu. It is circular muscle which gets hypertrophied, not the long chain muscle. Circular muscle hypertrophy. So these are the barium sign. Only remember the name. We don't have to know the detail. And this is a X-ray showing single bubble sign. This also, although rarely asked, you should know. Single bubble sign. Just one X-ray, one air bubble, single bubble sign. Remember, this is a non-surgical emergency. This is the electrolyte imbalance you get. This is the fluid of choice, N/2 saline, be it dextrose and potassium. Ringer lactate can be given, but it increases alkalosis, which is why it should be avoided. Though it's not contraindicated, but can be given, but leads to alkalosis, more alkalosis, which is why this is the fluid of choice. Once you have corrected the dehydration, you will not put more than 1 ml per kg per hour. Simply cut the muscle. You can see you have cut the circular muscle, and this is called Ramstead pyloromyotomy. Okay, very simple. And start oral feed within 6 hours because you have not opened the mucosa. Now, see another question. A 45-year-old smoker with history of prolonged NSAID presents with acute abdominal pain for 1.5 days. X-ray showed regular sign, which I'll explain to you. She undergoes laparotomy and a perforated ulcer on the anterior wall was found. Out of these 4, what is the best treatment for perforated adrenal ulcer? Can you tell me? Yes, Ranuma, you are correct. Ayan Bharti, yeah. So, no, this is not type 5 gastric ulcer. Type 5 is NSAID induced erosions. This is a duodenal ulcer, type 2. NSAID doesn't mean that always you have NSAID type 5. NSAID can cause duodenal ulcer as well. So answer is omental patch repair. Now look at the screen. Okay, before that, only duodenal or gastric ulcer is treated by omental patch. Ileal and jejunal perforation are not closed by omental patch. They are simply closed primarily. We call it primary closure. Take the needle, suture, and close it primarily. But for duodenum, first you put the omentum, then you close. That's called Graham omental patch repair. So I'm repeating, only for duodenum you will say, or stomach you will say Graham patch repair, not for jejunum and ileum. Look at the screen now. This is the stomach and this is the duodenum. This is, why not D? What is D? Okay, I'll tell you. So if the stomach perforates anteriorly or the duodenum perforates anteriorly, the pink area is the greater sac. So content will go into greater sac or air will go into greater sac, causing peritonitis and pneumoperitoneum. Right? So the stomach and duodenum both perforating anteriorly will cause pneumoperitoneum and peritonitis. Air will go up. air will get collected here. I'm using black color between liver and diaphragm, and you have air below diaphragm. That's the air which comes out from the bowel, goes up, gets collected between liver and diaphragm. So in X-ray you find air below diaphragm. So any anterior perforation of stomach or duodenum will cause pneumoperitoneum and peritonitis. But now I'm using blue color. But the duodenum perforates posteriorly, posterior perforation. This causes bleeding due to gastroduodenal artery. So, okay, so anterior gastric and duodenal perforation will cause peritonitis. Posterior and gastric and duodenal perforation will cause bleeding. Posterior duodenal perforation, sorry, will cause bleeding. Yes, doctor on wheel, you are right. We don't do vagotomy here, truncal or highly selective, because this is an infected case. Patient has come 1.5 days after perforation. If I'm operating within few hours, when the abdomen has not developed that severe infection, then we can think of doing vagotomy, but not in this case vagotomy, because here patient is coming late, the abdomen is infected, plus patient is also a little sick, so we'll not do vagotomy, we simply do a mental patch repair and we come out. Vagotomy can be done in very few cases, those who are being operated within few hours of perforation and they are very healthy and physically fit patient. So here answer is just A because of the delay. These signs you have to remember, only the names. These are signs of pneumoperitoneum. I will show you, but only remember the name. This you have to identify, rest you only remember the name. All these are signs of pneumoperitoneum. See, air below diaphragm, very important X-ray. Again, air below diaphragm, very important. That's the most commonly asked X-ray. Air below diaphragm is pneumoperitoneum, hollow viscous perforation. This is called cupola sign, where air connects both the diaphragm. So this is cupola sign, another sign of pneumoperitoneum. Although not important photo-wise, but name you remember. This is regular sign, where I can see the wall of the bowel. This white thing is bowel wall. When I can see the wall, this is called pyloroplasty. Is a drainage procedure. Drainage. When you have gastric outlet obstruction, not pyloromyotomy. Pyloromyotomy, we only cut the muscle. Pyloroplasty, we cut through and restitch. So pyloroplasty is not the treatment of ulcer. Suppose patient has scarring and gastric outlet obstruction, or after vagotomy he has gastric outlet obstruction, then you do pyloroplasty. Okay. So pyloroplasty is not the treatment of ulcer. It is when we do vagotomy, patient will have vagus is the motor supply of pylorus. So after vagotomy, pylorus function gets impaired. To correct that, you do pyloroplasty as an adjunct of vagotomy, as a support of vagotomy. Pyloroplasty is not the treatment for ulcer. So regular sign is, you can see bowel wall shown by white arrow. That's called regular sign. Regular triad is a triad of gallstone ileus. Regular sign is a sign of pneumoperitoneum. Okay. Only remember the name. Image will not come. Air below diaphragm is the only image that comes in exam. Rest you remember the name. These are signs of pneumoperitoneum. This is called Doge cap sign, where air gets trapped in the Morrison pouch, and this is called Doge cap sign. This is called falciform ligament sign here, when you see a white line of falciform ligament in X-ray. This is called inverted V sign, and this is called football sign. So all these are signs of pneumoperitoneum, air in the abdomen. I'll repeat. So we have inverted V sign in the lower abdomen, you get V shape. Cupola sign, both diaphragm connected by air. Football sign, mainly seen in children. Falciform ligament sign, regular sign, and Doge cap sign. Only remember the name. These are the signs. And this is the image of omental patch repair. You first put the omentum and you use Vicryl, VICRYL, absorbable synthetic polygalactane suture. That's best for GIT, 2030. Usually we use for bowel 30 or for duodenal ulcer we can use 20. So first put the omentum, then, and again I'm repeating, omental patch is not for bleeding ulcer, omental patch is not for jejunum or ileal perforation. It is only for duodenal perforation and really for gastric perforation, but it is for perforation, not for ulcer, not for bleeding. Understood? For bleeding, never say omental patch. For bleeding, say endoscopic sclerotherapy. समझ गए? तो ये नाम आते हैं. और एक चीज और याद रखना, you remember one more thing. Regular sign is a sign of pneumoperitoneum, but regular triad is a triad of gallstone ileus. That was a question of 2021 NEET. So these are the points you have to remember about perforation, right? Next question. Which of the following is not an X-ray of a small bowel obstruction? Can you tell me the answer of this? इन चारों में एक्सरे का कौन सा फीचर, which is not a feature of obstruction, X-ray feature? Yes, if the ulcer is on the posterior surface, then it will bleed. Then you go for sclerotherapy. You can do vagotomy along with that, but vagotomy is an open surgery. So we just do sclerotherapy followed by H. pylori eradication. For gastric perforation, Saurabh, best answer is Billroth 1 gastrectomy. But if the patient is not fit to undergo gastrectomy, we can go for omental patch repair even for gastric ulcer. But don't say patch repair as a first option. First option is gastrectomy. Second option is omental patch repair. Okay, for gastric ulcer also. So this is for sigmoid volvulus. Let's see the X-ray. This is a very, very, very important X-ray. This is multiple. It's as important as air below diaphragm. These comes under. They come under red zone of radiology for you very frequently asked. So multiple air fluid level. This is a string of pearl sign. Multiple air shadow like this, like this. This is called string of pearl sign. That's another sign of obstruction. This is called stack of coin sign. Multiple shadow like this. That's another sign of obstruction. So stack of coin sign, multiple air fluid level, string of pearl sign, all three are sign of obstruction. But what is northern exposure sign? See, this is the abdomen. This is the colon and this is the sigmoid. Sigmoid always will remain, the topmost part of sigmoid will always remain below the transverse colon. In case this sigmoid goes above transverse colon, that's called northern exposure sign. You can see here. This is the red line, is the asterisk is the transverse colon like this, and the blue is the sigmoid here. So the topmost point of sigmoid has gone above the transverse colon. This is called northern exposure sign, suggestive of volvulus. But bird on prey sign is a sign of barium enema. I'll make it very easy for you, RRR. For whole GIT, just say vicral, anywhere. Vicral, whether it's biliary surgery or GIT, vicral is the main suture for GIT, okay? So, and the X-ray that you have to remember is coffee bean shaped shadow like this. This is a very, very important X-ray for you, which suggests sigmoid volvulus. Inner bend tube. So inner bend tube or coffee bean shaped shadow called Freeman-Dahl sign. Although I'll write down the name of sign, but not important. You need to remember the name of this sign. They won't ask the name. This is called Freeman, Freeman, DEHL, Dahl sign. So this coffee bean shadow is called Freeman-Dahl sign. This, I would say, is a very, very, very important X-ray for you. But you should also know the name. This will not come in exam image, but remember, northern exposure sign is a sign of sigmoid volvulus, while stack of coin, string of pearl, and air fluid level, they all suggest obstruction. Next question. A 65-year-old man presents in emergency with several days of jaundice followed by 12 hours right on open. So patient has jaundice but now he is having pain for last 12 hours with fever and chills. No, GP66, let me go back to this image so that you understand. GP66, see here. A posterior gastric ulcer, see the red arrow. The content goes into lesser sac. The blue area is the lesser sac. So they also present with peritonitis. They don't present with bleeding. So they are treated by gastrectomy. Like anterior, posterior, the same treatment. Posterior adrenal ulcer is treated by sclerotherapy. It presents with bleeding. So this question here suggests that this is cholangitis. Okay. This question here suggests it is cholangitis. What I mean by this, let's understand. This is the liver. This is the right and left hepatic duct, and this is common hepatic duct and gallbladder and common bile duct. Cystic duct combines with common hepatic duct, forming common bile duct. When the stone is in the gallbladder, it presents with cholelithiasis. So it causes cholecystitis, diagnosed by ultrasound, treated by cholecystectomy. So cholecystitis only presents with pain and fever, not jaundice. Only pain, maybe fever, but no jaundice. But when the stone comes into CBD, this is called choledocholithiasis. Now the patient will have jaundice. So any gallstone patient, if he develops jaundice, think of stone in the CBD, and it can in fact progress to Charcot striate. What is Charcot striate? Pain, fever, and jaundice. And all three intermittent: pain intermittent, fever intermittent, jaundice intermittent. So when the patient comes with Charcot striate, think of CBD stone, or jaundice, think of CBD stone, not of gallstone. And now this can develop septicemia, and patient can have Reynolds pentad. So now pain, jaundice, fever, patient has developed shock and coma as well. So Charcot striate and Reynolds pentad are features of CBD stone, cholangitis. And now this is an emergency diagnosed by MRCP and treated by ERCP. So neither we order MRCP or ERCP for a simple gallstone. We do ultrasound and we operate. But in case you suspect CBD pathology, and why you suspect? By jaundice or high-grade fever or septicemia or shock coma, then you go for MRCP. That is for investigation. MRCP treated by ERCP. ERCP and decompression should be immediately done. Otherwise, patient will die of septicemia. So, like here, see, when the stone is in the gallbladder, presents with cholecystitis, diagnosed by ultrasound, treated by laparoscopic cholecystectomy. But when the stone is in CBD, it presents with cholangitis. What is the presentation of cholangitis? Pain, fever, jaundice, may progress to Reynolds pentad. And then you go for MRCP to confirm. If I say what is the investigation for CBD stone? MRCP. And how do you treat ERCP? Someone having gallstone and CBD stone, first, how you manage that? First CBD, then gallbladder. So first you do ERCP always, followed by cholecystectomy. Never other way around. Never say I'll treat gallbladder first and then CBD. No. First ERCP followed by cholecystectomy. Very simple approach. So I guess this question is basically why we say it's CBD problem. Because of three things. Number one, patient having hypotension, fever, chills, and dilated CBD, and intrahepatic bile ducts are dilated. So naturally, antibiotic MRCP to diagnose, followed by ERCP. So answer is D. I don't think there's any confusion or problem here. First MRCP to diagnose, then ERCP. All sigmoid volvulus or cecal volvulus are derotated and you fix. In case you have gangrene, then you go for Hartmann's procedure. Okay, we have a question on that. So ultrasound, they don't ask an exam except few. This is a gallstone. How you identify gallstone? A echogenic shadow followed by acoustic shadow behind it. If there's like here, these are the echogenic shadow here followed by acoustic shadow. If we do not find acoustic shadow behind, then this is a polyp. T-tube is placed, Saurabh, when we do open surgery. In case ERCP fails for CBD stone, then you have to do open surgery. So in open coldocolothotomy, that is followed by T-tube. So T-tube is not placed in ERCP. In ERCP, we place stent. That's called stent, not T-tube. So I'll repeat, T-tube is only placed when you're doing open surgery, okay? So this is polyp, which does not have acoustic shadow, and here you can see acoustic shadow. Here, this is acoustic shadow. This is how you differentiate. Number 2, all polyp less than 10 millimeter managed conservatively, more than 10 millimeter should be removed. So you do cholecystectomy for polyps which are asymptomatic, more than 10 millimeter. Less than 10 millimeter, only conservative. That's another question they ask, okay? And this is called vestroid, which is a feature of cholecystitis, chronic cholecystitis. Option B, what is option B here? No, we don't do this. This can be done if ERCP fails. First thing should be ERCP. Like after MRCP, I'll do ERCP and remove the stone or put a stent. But in case ERCP is not successful, then only we go for open surgery, remove the stone, or clear the CBD and put a T-tube inside. So this option is only when ERCP fails. So vestroid is a triad of chronic cholecystitis, where W is wall, E for echogenic shadow, and S is acoustic shadow. This is simple triad of chronic cholecystitis. Another thing they asked, this was a 2022 INICT question. What mean by 1 centimeter? Yeah, 1 centimeter you should remove, polyp size I guess. So this image they ask and ask what it is, just photo. So this is cholesterolosis called strawberry gallbladder. Strawberry gallbladder basically is when the cholesterol crystals accumulate in the mucosa of the gallbladder, maybe forming a polyp. Small polyp can be cholesterol polyps. So this is the image they do ask. For gallstone, asymptomatic stone less than 3 centimeter, you can manage conservatively. More than 3 asymptomatic, more than 3 centimeter should be removed. For asymptomatic gallstone, for polyp, 1 centimeter. So this is one image they do give. This is another condition called adenomyomatosis, where the mucosa go deep in muscle, forming Rokitansky-Ashov sinus, and then inspission of bile and muscle dystrophy. So adenomyomatosis is a condition where, and both strawberry gallbladder and adenomyomatosis are managed conservatively unless they are symptomatic. You can manage conservatively. So adenomyomatosis, where the mucosa dips in the muscle, forming Rokitansky-Ashov sinus and dystrophy of the muscle. In MRI, they give pearl necklace sign, and in ultrasound, they give comet tail sign. Comet tail sign, which is MCQ. Okay. So that also they do ask in gallbladder. See another question. False statement regarding gallbladder cancer. Can you tell me the answer? T1A is treated by cholecystectomy. T2 is treated by extended cholecystectomy. External port site improves survival. And inter-aortocaval node are inoperable. What is wrong here? What is wrong here? Gallbladder causes we have seen last year in NEET and then this year in INICT. The wrong statement is C. Port site excision is not recommended now. Let's first understand the risk factor for gallbladder cancer as well as cholangiocarcinoma, both. Because last week NICT, last year NEET, we had question on this. So risk factor are, number 1, all hepatic cyst, congenital cyst. So congenital hepatic cyst, number 1, Caroli's disease, number 2, choledochal cyst, number 3, and there's a condition called von Meyenberg complex, number 4. Von Meyenberg. What is von Meyenberg complex? The bile duct inside the liver are not properly formed. They don't communicate with hepatocyte. This is called biliary hamartoma. Biliary hamartoma. So von Meyenberg complex, choledochal cyst, Caroli's disease, and hepatic cyst. They all are risk factor for cholangiocarcinoma. Then primary biliary cirrhosis. Then, no, cirrhosis is not a risk for gallbladder cancer and cholangiocarcinoma. No, not cirrhosis. Primary biliary cirrhosis, only PBC, not hepatitis A, B, etc. Number 3, sclerosing cholangitis, primary sclerosing cholangitis, with or without ulcerative colitis. Number 4, ulcerative colitis. Number 5, 2 worms, one asked last year, one asked this year. Clonorchis sinensis, fish worm, and Opisthochus. Opisthochus. Clonorchis sinensis and Opisthochus. Then certain toxins. In toxins, you can write thorotrast and arsenic and some more, even radiation. Then certain drugs. In drugs, although the risk is very low, but still one should know. Estrogen, INH, isoniazid antitubercular drug, and alpha methyl dopa. Then stone, gallstone, cholelithiasis. Gallstone is mainly for gallbladder cancer, not really for CBD cancer. And finally, chronic typhoid carrier. Chronic typhoid carrier. So these are the risks. I'll repeat. This year, last week, the NICT question was, which is not a risk factor? The options were primary biliary cirrhosis, Caroli's disease, hepatitis B, and there was one more, Opisthochus. So hepatitis B is not for cholangiocarcinoma, that is for hepatocellular cancer. Okay, so these are the risks you have to remember. I'll repeat. All congenital liver cysts. Hepatitis B is not. Hepatitis B very rarely can cause intrahepatic cholangiocarcinoma. Can cause. But that is very rarely, okay? That's not considered risk factor for cholangiocarcinoma. It's risk factor for hepatocellular cancer, right? That is the question last week only. So, hepatic cyst, Caroli's disease, choledochal cyst, and von Meyenberg complex, primary biliary cirrhosis. Well, Mohit, in pregnancy, you can very well do lap surgery provided depends on which trimester you are operating. First trimester, because uterus is very small, so lap can be easily done. but the drug will have more reaction in the fetal development and certain side effects. Advanced cases, the uterus is quite big, so laparoscopy is difficult. One should go for open. But this is not an absolute contraindication, it all depends. So thorotrust, arsenic, so all these are risk factors. Now coming to treatment, T1A and TIS is only treated by cholecystectomy. T1B, T2 and T3 are treated by extended cholecystectomy. So T1A and TIS only treated by cholecystectomy. T1B, T2 and T3 are treated by extended cholecystectomy, and port site excision does not improve survival. Port site excision can be done for the purpose of prognosis only. It has no role in survival. Okay? A 39-year-old previously healthy male is hospitalized. 10 days of epigastric pain, nausea, vomiting. Amylase is high. So a diagnosis of pseudocyst you can think of. There is a cystic swelling here, and only 2 weeks have passed. After 2 weeks, with fever, high TLC count, what is this? Yes, gallbladder cancer presents with cholecystitis pain only. Option D. Yeah, that is inoperable. That is considered metastasis. Retroperitoneal lymph node, that's intertrocheal, is inoperable. That's correct. So, this is a peripancreatic fluid collection. This should be treated by antibiotic and percutaneous drainage. This is the answer. Why not normal cystogastrostomy? Carolese is not intrahepatic. Carolese can be extrahepatic as well. There may not be a cyst in gallbladder, but it increases the risk of gallbladder cancer. Carolese also cholangiocarcinoma as well as gallbladder cancer, both. So why not D? This is only done after 6 weeks of history, not before 6 weeks. No, in infection also you can do this, but it should be more than, yeah, that's correct answer, Sahil, immature wall. The wall become mature after 4 weeks. So before 4 weeks we don't call it pseudocyst, and before 6 weeks we don't operate. Whether infected or non-infected, we cannot do cystogastrostomy before 4 weeks. The cyst has not formed and the wall is not fibrous. So wall becomes fibrous only after 6 weeks. So remember, cystogastrostomy can only be done after 6 weeks, and here the history is only 2 weeks. You see, history is only 2 weeks, which is why we have to drain it outside. IOC of cholangiocarcinoma, you are saying? IOC for cholangiocarcinoma is CCT, contrast enhanced CT. All other, because I cannot see the last word, all other CBT pathology, stricture, stone, or cortical cyst, it is MRCP. But for carcinoma, it should be CCT. So I hope this point is clear, that any cyst before 4 weeks is managed conservatively. You don't operate. Obesity is not. So you don't drain the cyst before 4 weeks. You only drain when it gets infected, and after 4 weeks, when it has become a proper cyst, then wait for 6 weeks and do cystogastrostomy. Is this clear? Never say cystogastrostomy before 4 weeks. No, not after 4 weeks. After 4 weeks, it's a cyst forms. After 6 weeks, we go for surgery. Yes, then you should open the cyst, drain all the infected material, and drain in the stomach, cystogastrostomy. That will be the permanent treatment, Mohit. Okay? So this is the what points you need to know about pseudocyst. Just 5-6 points. Number 1, what is the most common site? You can see behind the stomach, anterior to pancreas. Most common site is lesser sac. Most common site. Why pseudocyst is called pseudocyst? Because it does not have epithelial lining. It is lined by granulation tissue. So no epithelium, which is why it is called pseudocyst. Why not option B? What is option B? No, you don't have to repeat imaging. That depends. First thing is antibiotic and drain. CT guided, ulcer guided, whatever. So second point is no epithelium, which is why we call it. Opus thoracus is a worm, which is why it is called. So number 3, can be caused by acute, chronic or trauma. Acute pancreatitis, chronic pancreatitis or trauma. This is another question. This is another question. What is the most common cause of pseudocyst in children? Trauma. Overall, acute, but in children, trauma. Number 4, what is the most common complication of pseudocyst? Most common complication is infection, followed by hemorrhage. So, most common site, lesser sac. No epithelial lining, so it's called pseudocyst. Acute, chronic and trauma, all 3 can cause. Most common in children is trauma cause. Infection is most common complication. Can be communicating with the duct or non-communicating with the duct. It can communicate or non-communicate. And we do have a classification called DAMS-eMedicoz. This is how it forms. DAMS-eMedicoz classification based on communicating or non-communicating. Investigation or choice is CECT. And treatment is cystogastrostomy, only done after 6 weeks. So these are the points they do ask in MCQ. You have to remember. Chronic and trauma are communication. Sahil, you are absolutely correct. Acute is non-communicating. And you can see here, a edematous pancreas develops collection. We don't call it pseudocyst before 4 weeks. Why? Because the wall has not formed. The wall forms after 4 weeks, becomes mature, and then you operate. That's after 6 weeks. Amylase is definitely high, and if CEA is high, then this is mucinous cyst adenoma, not pseudocyst, which is why CEA has some role here. High CEA means mucinous cyst adenoma, okay, not pseudocyst. CEA should be absent. So these are the points you need to know. This is a pseudocyst here. These are the points they ask. Now the last question of GIT, then I'll move on to urology, another 15 minutes. Because we started late also. So the points I told you are basically MCQ, single liners. Can you tell me what procedure is being done here? The patient is in lithotomy position. This is the anal canal. There's an opening here. And this scope is going through this opening. So what is this procedure? Yes, this is WAFT. It's surgery for fistula. WAFT stands for Video Assisted Anal Fistula Treatment. Video Assisted Anal Fistula Treatment. We pass a fistula scope through, like here. This is the fistula. So you pass a fistula scope from inside and burn the complete tract. Yes, GP 66. For cyst and tumor, best is CECT. That's correct. So you pass a scope and burn the tract from inside, called WAFT. What about lift? That is also for fistula. That's called ligation of intersphincteric fistulous tract. Ligation of intersphincteric fistulous tract. And what is FILAC? Fistula laser closure. Laser, diode laser is used. Fistula laser closure. So, this is the anorectal ring here. Fistula going above the ring are called high type. Remains below the ring is called low type. So remember how high and low is divided by anorectal ring. And all fistula open where? At dentate line. That's another important question. Fistula open at the black line is the anorectal ring. Now I can say this green line is the anorectal ring. Fistula going above this are high type and below this are low type. What is this question, Arshdeep? Pseudocyst is more common in chronic cholecystitis. Pseudocyst is a problem of pancreas, not gallbladder. I don't understand your question. So, high type and low type are divided by anorectal ring shown by green color. Another important point, this is called dentate line, the blue line. All fistula open at dentate line. Those who open above green line are called high type. So, all high type can lead to sphincter damage. If you operate, you can damage the sphincter, you have to be a little cautious. Low type are treated by fistulotomy. High type is treated by ceton wiring. So any surgery, if you do fistulotomy for a high type, you can damage the sphincter. So for high type, what you do ceton, S-E-T-O-N. And for low type, what you do? Fistulotomy. Fistulotomy cannot be done for high type, otherwise patient can develop sphincter damage, sphincter can get damaged. So low and high type is divided by this black line called anorectal ring. Why it is important to know low and high type? Surgery depends on that. What is the IOC gold standard for fistula? MRI. MRI is IOC. And the types are the types of fistula: internal sphincter, external sphincter. This black line is intersphincteric, going in between the sphincter, most common type. This red is transeccentric, second most common type. So black and red are low type, right? Like intersphincteric, transsphincteric. This green is suprasphincteric, and this violet is extrasphincteric. So green and violet are high type. They cannot be treated by fistulotomy because you can damage the sphincter. And most common is inter and transsphincteric. Black is intersphincteric, red is transsphincteric. They are low type. They can be treated by fistulotomy. Now this is the dentate line. Hemorrhoid is divided into internal and external by dentate line. But fistula is divided into low and high type by anorectal ring. So I'm repeating. Hemorrhoid is divided into low and high type by dentate line. Fistula is divided into in hemorrhoid internal external by dentate line. Fistula low and high type by anorectal ring. Banding can only be done for internal hemorrhoid, not external hemorrhoid. Banding for internal because that's painless. External is painful. Below dentate line, this mucosa is squamous and pain sensitive. And above dentate line, mucosa is columnar and pain insensitive. So we can only use banding for internal hemorrhoid, not for external hemorrhoid. And in pancreatitis, in pseudocyst, if you compare acute and chronic, a persistent cyst is more common in chronic pancreatitis. Persistent cyst. Acute they do develop, but they disappear. So overall common in acute, but persistent cyst is more for chronic. So rubber band ligation only for internal hemorrhoid because that's painless, not for external. Okay. So is this thing clear? Somewhat clearer? Now let's come to urology. Last week I saw one question from Adrenal basic anatomy, and last year also I saw one question for Adrenal anatomy. So I thought, why not discuss the basic of Adrenal? If you have any doubt, you can write down, then I'll start this. So Adrenal deep ring is at the midpoint of inguinal ligament. There's no confusion about it. Okay. Not mid-inguinal point, midpoint of inguinal ligament. Okay. Mohit. So this, listen very carefully for next 5 minutes. This is the right kidney, this is the left kidney. Which kidney is lower? Right. Just remember, liver pushes the kidney down. But the right adrenal is triangular and the left adrenal is concentric. So the shape of right adrenal like this, left adrenal like this. Due to its shape, it is the right adrenal is higher. So I will repeat. Right kidney is lower, but the right adrenal is higher due to its shape. Okay? Adrenal weighs about 35 grams and measures 3 to 5 centimeter. Now, adrenal has two parts, outer cortex and inner medulla. Cortex is mesodermal, medulla is neuroectodermal. Cortex is 90%, medulla 10%. So cortex, mesodermal, and medulla neuroectodermal. Okay? Cortex has three layers, GFR. Zona glomerulosa, zona fasciculata, zona reticularis. Glomerulosa produces aldosterone, mineralocorticoid. क्या काम होता है इसका? Sodium and water absorption and hydrogen and potassium excretion. Yeah, neural crest, medulla is neural crest, that's correct. So sodium, water ka absorption and potassium, hydrogen ka excretion, which is why if aldosterone is produced less, Addison's disease, what will happen? More potassium, more hydrogen, क्योंकि कम बन रहा है. Acidosis and hyperkalemia and hyponatremia and dehydration, because कम बन रहा है. ज्यादा बनता है. Conn syndrome, C-O-N-N, Conn syndrome. More aldosterone. What will happen? Hyponatremia, water retention, hypokalemia, alkalosis. Very simple. Listen carefully what I'm saying. Sodium and water is absorbed and potassium hydrogen excreted. So more aldosterone means sodium and water more, potassium hydrogen less. So one question, very important question, which is not a feature of Conn syndrome? Hyponatremia, water retention, hypertension, hypokalemia, alkalosis, all you'll get. What you'll not get? Edema. Edema is not a feature of Conn syndrome frequently. Why not? When sodium is retained, NAP, natriuretic peptide, atrial natriuretic peptide has created NAP, and that leads to diuresis, and edema is not a feature. Okay? So this is what they ask very commonly. So hypokalemia, alkalosis, hypertension, hyponatremia, water retention. These are the features. Fasciculata will produce glucocorticoids, Cushing syndrome, and reticularis will produce sex steroid, androgens. If it can lead to pseudohermaphroditism, cortical adrenal hypertrophy, and 21-hydroxylase is the most common deficiencies. Yeah, aldosterone escape phenomenon, that's correct. Now, medulla produces epinephrine and norepinephrine. Now listen very carefully. Medulla produces 90% epinephrine, 10% norepinephrine. But when there is a tumor, pheochromocytoma, then this ratio is reversed. More norepinephrine, less epinephrine. And in case it is malignant pheochromocytoma, then more dopamine. So I will repeat, medulla produces more epinephrine normally, 90% epinephrine, 10% norepinephrine. But in pheochromocytoma, it reverses, more norepinephrine. And in malignant pheochromocytoma, more dopamine. And the tumor of adrenal medulla is called pheochromocytoma. As far as blood supply is concerned, this is the aorta, this is the renal. Okay, let's first draw renal vein. So this is the diaphragm, this is the IVC, this is the renal vein, and this is the aorta, and this is the renal artery. This is the right kidney, this is the left kidney, and this is the right adrenal and this is the left adrenal. Adrenal receives 3 artery and 1 vein. It drains to 1 vein. The arteries are inferior phrenic artery, aorta, and renal artery. So it takes supply from 3 arteries: inferior phrenic artery, aorta, and renal artery. But vein is only one on the right side, IVC, on the left side, left renal vein. So vein is only one, right side drains into IVC, left side drains into the left renal vein. Yes, in extra-adrenal, Medico, I'll answer your question. Just give me 1 second. Medico aspiring, just give me 1 second. Let me finish this. I'll explain. I'll make the comment one clear. Just listen. So right renal vein does not receive any tributary. Left renal vein receives testicular vein from below, second lumbar from behind, and adrenal from above. So left renal vein has 3 branches coming here. नीचे से testicular, पीछे से second lumbar, ऊपर से adrenal. But right renal vein does not have any branch. Okay? So adrenal takes supply from 3 arteries: inferior phrenic, aorta, and renal artery, and drains only by 1 vein. The right side, right side vena cava, left side, left renal vein. Okay, understood this? Now coming to your question, medico aspiring, DOPA becomes dopamine. Dopamine becomes norepinephrine, which becomes epinephrine, and of course tyrosine with hydroxylase becomes DOPA. So there's one more step here. Tyrosine becomes by hydroxylation DOPA. Now from epinephrine, norepinephrine to epinephrine, this is called methylation, caused by methyl transferase. And methyl transferase is only present in adrenal medulla. Sympathetic ganglion do not have this hormone, so enzyme, I mean to say, they cannot convert norepinephrine to epinephrine. So only adrenal medulla can convert norepinephrine to epinephrine due to the presence of methyl transferase, methylation. So only medulla can produce epinephrine. If it is extra-adrenal called paraganglioma, they cannot convert norepinephrine to epinephrine. So how they will produce epinephrine? So all paragangliomas, they only produce norepinephrine, extra-adrenal, because they cannot methylate and convert norepinephrine to epinephrine. Is this point clear, medico aspiring? So only adrenal medulla can produce epinephrine more than norepinephrine. Adrenal medulla के बाहर sympathetic ganglion will have more of norepinephrine. Okay, and in malignancy dopamine. Yeah, there was one more question. कुछ men के बारे में कोई सवाल था यहाँ पे? In men also, yeah, you can have more epinephrine in men, but eventually they will produce norepinephrine. So this is about the question. Let's see here. 3 arteries: inferior phrenic, aorta, and renal artery. I'll use black color. Inferior phrenic, aorta, and 1 vein on the right side, IVC, left side, renal vein. Is this clear? So that's 1, and these are the layers: cortex, mesodermal, medulla, neuroacrodermal, 3 layers, GFR, and you know the product. Cystostomy is SPC, bhai. SPC का full form is suprapubic cystostomy. So if the bladder is full, you should do SPC, suprapubic cystostomy, if the bladder is full. So let's see the question. Each adrenal supplied by 3 artery, 1 vein, that's correct. That's correct. Left adrenal vein does not drain into IVC. Left adrenal vein drains into the left renal vein. Right drains into IVC. The wrong statement is C. Medulla has no postganglionic innervation. That's also correct. So I guess now adrenal concept should be clear. इस पर सवाल आ रहे हैं, पिछले 2 साल से आ रहे हैं. Now, what is not a contraindication of ESWL? So can you tell me the answer of this question? Not a concept of ESWL. This is a PYQ. पहले सवाल आ चुका है ये. Prosthetic valves are not a contraindication. See, if this is the kidney, these are the minor calyces, then major calyx, pelvis and ureter. A stone in minor calyx can be kept under observation. So, or if they are symptomatic, treated by ESWL or RIRS, especially for lower calyx, RIRS is better. For pelvic stone, less than 2 centimeter, ESWL or RIRS, more than 2 centimeter, PCNL. What is RIRS? Retrograde intrarenal surgery. Here we pass a flexible ureteroscope using holmium-Yaag laser. We break the stone and take the content out, and that is RIRS. Now, what is ESWL? Extracorporeal shock wave lithotripsy. You break the stone by shock wave, developed by a scientist named Chaucy. Chaucy was the name of the scientist who developed ESWL, and the company was Dornier, D-O-R-N-I-E-R. Dornier was the company which developed ESWL concept. First of all, what are the contraindications? Absolute contraindications are: number 1, bleeding disorder, uncontrolled. Number 2, pregnancy. Number 3, distal obstruction. If there is a ureteric stricture or any distal obstruction, you cannot do this. Relative contraindications are size more than 2 centimeter, children, hard stone. What are hard stone? Number 1, calcium oxalate monohydrate and cysteine. Calcium monohydrate and cysteine, hard stone. Then uncontrolled hypertension, very severe infection, pyonephrosis kind of infection. No, in any bleeding disorder, neither you can do ESWL nor PCNL. You have to correct the bleeding disorder first, only then you go for it. Cysteine and calcium oxalate monohydrate are the 2 hard stone. Infection. Then calcified aortic aneurysm. Stone in calyceal diverticulum. In the calyx, there's a diverticulum and there's a stone in the diverticulum of the calyx. You cannot do. Morbid obesity. Morbid obesity, very hard stone. Morbid obesity, stone in calyceal diverticulum, severe infection, hypertension, size more than 2 centimeter, children, all these are relative contraindication. So, and what are the problems? One side effect they do ask, that is stenosis. S-T-E-I-N-S-T-R-A-S-S-E. In stenosis, you break the stone here, the fragment they get collected in the ureter. So you have multiple small fragments in the ureter impacted in ureter. This is called stenosis. So you put a stent, DJ stent, then you break to avoid stenosis for big stone. Pacemaker is a contraindication, but prosthetic valve is not a contraindication. So this also you need to remember the shape and size of the crystals. Coffin lid crystals are phosphate. So oxalate, calcium oxalate dihydrate. Most common stone, most common stone, and any pH it can form. Triple phosphate, only alkaline pH in infection. Cysteine, only acidic pH. And triple phosphate forms the struvite stone or staghorn calculus. Staghorn calculus is phosphate, struvite stone. So this is the calcium oxalate envelope, this is cysteine hexagonal, this is coffinlate phosphate, and this is uric acid. And calcium oxalate are bipyramidal, monohydrate. Dihydrate is more common, monohydrate is bipyramidal. For lower calyx stone, like a stone in this calyx here, ESWL is considered not very good because the clearance is poor, but this is not contraindicated. So clearance is poor, so RIRS is better. I told you earlier RIRS is better, but still for lower pole it's not contraindicated, one can use. But the success is poorer than upper pole. So these are the points they do ask. Struvite stone forms the staghorn calculus, and this is mainly seen in infection. Okay. Now, during evaluation of undescended testis, a laparoscopy was performed which shows testicular artery entering into the internal ring. What should be the next step in the treatment of this patient? Can you tell me? Abandon the procedure, orchidectomy, orchidopexy should be done from outside, or Stephen Fowler technique. The varicocele can be treated by varicocelectomy or Palamo operation or embolization. There are many treatments, but embolization has the least recurrence rate. So varicocele embolization has the least recurrence rate. The best answer is C. If the artery is entering into the internal ring, it simply means the testis must be in the inguinal canal. Let's understand the undescended testis. What's the difference in inguinal exploration? That's correct. That's the right answer. The difference in undescended testis and ectopic testis is undescended is in its normal path of descent. Ectopic deviates from its normal path of descent. डिस्टल स्टोन का क्या मतलब? जो यूरेटर में है, प्रियांशु. What do you mean by distal stone? Like this is the kidney, this is the ureter. So PCNL means you are putting a scope from here, from the skin. If the stone is here in the ureter, I will pass a ureteroscope and take the stone out. So by distal stone, if you mean ureteric stone, no, we don't go from PCNL. We do ureteroscopic removal. PCNL is only for pelvic stone, calyceal and pelvic stone. Once it's in the ureter, you do ureteroscopy and removal, RIRS, or rigid ureteroscope. For lower ureter, rigid, and for upper ureter, RIRS. So undescended means it's in the normal path of descent. Ectopic means away from normal path. Undescended, most common site is inguinal canal. Ectopic, most common site will be superficial perineal space. So what are the complications? URS is called ureteroscopy. URS is short form for ureteroscopy. So PCNL full form is percutaneous nephrolithotomy. So what are the complications of undescended testis? Number one, you can remember SATHI, Sati. S is sterility, A for atrophy, T for torsion and cancer tumor. Which is the most common tumor is undescended testis? Seminoma. Seminoma is otherwise also most common tumor. H for hernia and I for inflammation. Make it easy. Another question. What is the most common complication? What is the most common associated finding with undescended testis? Most common is hernia, which you see in 90% cases. So undescended testis, hernia is the most common associated finding. more common than infertility or cancer. So I can ask another question. In undescended testis, we have to do orchidopexy. Which other surgery I'll do along with this? Herniatomy. So hernia is very common, 90%. First we order ultrasound, then if not seen non-palpable testis, we go for laparoscopy. The time of surgery is 6 months to 1 year. More than 2 centimeter PCNL is better. Less than 2 centimeter, ESWL or RIRS both can be done. So 6 months to 1 year. What you do in laparoscopy? Question number 1. How you locate the testis? By following testicular artery. Follow the artery and you will find where the artery goes. That's the testis. Question number 2. If the artery is ending blindly, ends without supplying any tissue, inguinal, congenital inguinal hernia. That's correct, Meet Patel. So if the artery ends blindly, what do you do now? What does it mean? Anorchia. Anorchia means agenesis of testis. That's another AIMS question. What is the best investigation for agenesis of testis? Laparoscopy. So if the artery ends blindly, what you do? Don't do anything, just leave. You cannot do anything. If the artery ends into the internal ring, what you do? Explore from outside. That testis must be in the canal, inguinal exploration. And if the artery supplies a testis, but testis is high up in the retroperitoneum, you cannot bring it down in one stage, then you go for a Stephen Fowler technique. Let me show and explain. This is the abdomen. This is umbilicus. My laparoscope has gone from here, from the umbilicus. This is the internal ring, this is the external ring, and this is the canal. This is the testicular artery and the testis is here. If it is in the canal, I can bring it down, but it's here. This violet round thing is testis above the internal ring in the retroperitoneum. Then we go for Stephen Fowler technique. When the testis is high up, you cannot bring it down in one stage. Okay? So this is what they have asked. And so answer is this. When we do Stephen Fowler technique, when it's a high testis above the internal ring. And when we abandon the procedure, when testicular artery ends blindly. So these are the question you have. How you locate the testis in laparoscopy? Follow the artery. Where the artery goes, that's a testis. And what is the IOC for agenesis? Laparoscopy. These are 5-6 questions they have asked. Now let's see this question. After chemotherapy for high bulk non-seminomatous testicular cancer. Okay, sorry, my fault. This is the wrong question. Question is after high orchidectomy. This is totally misprinting. After high orchidectomy, a non-seminomatous cancer was found. And patient has a, when we do B, what is B? Yes, in undescended testis, if you have a small nodule, but that is not a properly formed testis, that is a atrophic testis called nubbins, N-U-B-B-I-N-S. So that testis is absolutely useless, and that's testicular nubbins, residual testis atrophic, although it has malignant potential. So it should be removed immediately. Orchidectomy you do for atrophic testis, nubbins. So can you tell me the answer? Now this is the first question where I see wrong answer. Otherwise you were absolutely correct. I think you have not been told that radiation has no role in non-seminoma. Radiation is only used for seminoma. Chemotherapy is the treatment. C, for seminoma, first thing is high inguinal orchidectomy. Followed by seminoma, stage 1 or stage 2A. 1 means confined to testis or less than 2 centimeter. We can go up to 2 centimeter lymph node mass. we can go for radiotherapy. Radiotherapy is only for seminoma, where you give and no, you don't rule out malignancy because you are operating at the age of 6 months to 1 year. Malignancy patient develop after puberty, not at this age. So what radiotherapy you give? Look at the screen. We don't give radiotherapy to the scrotum because the testis you have already removed. Radiotherapy is given to retroperitoneum like this. This is called inverted Y field radiotherapy. For seminoma, you give lymph node radiotherapy, inverted Y field radiotherapy. And this is also called dog leg field radiotherapy. So for seminoma early stage, only for seminoma, not for non-seminoma, you can give radiotherapy, inverted Y field or dog leg field. Dose is around 2,000 rats to 3,000 rats. Seminoma is very, very radio-responsive. This is half the dose that normally we give for any cancer. So it's very radio-responsive. ये मक्खन की तरह पिघल जाता है radiotherapy से. So very low dose. 1,500 to 3,000 rats. And so only for early stage. No inguinal radiotherapy, no pelvic, only iliac and retroperitoneal lymph node. For advanced stage 2C and 3, we give chemotherapy. 2B depends, इधर और इधर दोनों तरफ आ सकता है, ज्यादातर chemotherapy. Okay? And chemotherapy, although there are half dozen regimes, but for last 25 years, as you have rightly written, Priyanshu, we give PEB regime. P stands for cisplatin, E for etoposide, B for bleomycin. So chemotherapy is generally cisplatin, etoposide and bleomycin. The main side effect of cisplatin is nephrotoxicity, etoposide is neurotoxicity, and bleomycin is retroperitoneal fibrosis or pulmonary fibrosis. And etoposide is also called VP16. That's another name for etoposide, VP16. Another name. So this is for seminoma. For non-seminoma, after and remember, high orchidectomy from the inguinal area, like you're operating hernia, not from the testis. No FNSC, no biopsy, no testicular procedure. Directly high orchidectomy. For early stage 1 and 2A, yes, for stage 2 you can give chemo. 1 and 2A, you do RPLND, retroperitoneal lymph node dissection. And for advanced stage 2B, 2C and 3, we go for chemotherapy. Same drug. After chemotherapy for residual tumor, you can do RPLND, but now we have PET scan, so we order PET scan if there's or more than 3 centimeter size, or there's activity in PET scan, then you do RPLND. Otherwise, it can be fibrous nodule. So in this question, actually, I wanted to make this question that this is a non-seminoma around 4 centimeter. The best answer should be chemotherapy. Although this is not a good question because less than 5 centimeter, even RPLND can be done. So this question little controversial. What I have made, there's some printing problem here, misprinting is there. So the question has changed somehow. So I'll just repeat the treatment verbally. For seminoma and non-seminoma, first step is high orchidectomy. For seminoma, early stage radiotherapy, advanced stage chemotherapy. For non-seminoma, early stage RPLND, advanced stage chemotherapy. After chemotherapy, if tissue is left behind, you can go for RPLND if it is big or PET scan showing activity. Okay. Now the last question and some MCQ. Answer given is D. And this is actually the size less than 5 centimeter, you can go for RPLND. But now so that is why the answer is given D. But now rather than less than 2 centimeter, we go for RPLND. More than 2, we go for chemotherapy. So this is not a good question. As I told you, there's some problem in this question. But still, I think this is the best answer. Now, some inclusion body in testicular tumor. This was a question last year. Rinke crystal, these rod-like structure intracellular, they are found in Leydig cell tumor. Rinke crystal. Schiller-Duval body, this is a question asked earlier, you get in yolk sac tumor. Yolk sac tumor. And remember the names only. You don't have to identify the image, they only ask the name. And Karl-Exner body, we get in granulosa cell tumor. I can tell you some one-liners for testicular tumor. Most common testicular tumor is seminoma. In old age, most common is lymphoma. Within 6 months, most common is granulosa cell tumor. In children, like 2-3 years, most common is, I will tell you GP66, yolk sac tumor. Within say about 10 years, most common yolk sac. In second decade, puberty, most common is teratoma. But from 20 to 40 years, most common is seminoma. Overall, most common is seminoma. In hermaphrodite, intersex, hermaphrodite, or you can call it intersex, most common is gonadoblastoma. In undescended testis, most common is seminoma. And in undescended after surgery, when you have done orchidopexy, आप testis को नीचे लाके fix कर चुके हैं. So after surgery, when you have brought the testis down, orchidopexy has been done, then most common is embryonal cell cancer. So undescended is seminoma. After orchidopexy and undescended, embryonal cell cancer. And chromosome 12p, isochromosome 12p mutation is most commonly found in testicular tumor. So the points you need to remember, most common is seminoma. In old age, most common is lymphoma. Within 6 months, most common is granulosa cell tumor, Karl-Exner body. In children, like 2, 3, 5 years, most common is yolk sac tumor. In second decade, puberty, around say about 8, 9 years till 15 years, most common is teratoma. In hermaphrodite, most common is gonadoblastomoma. And undescended testis, most common is seminoma. After surgery, most common is embryonal cell cancer. Okay, these are the points you have to remember. Investigation wise, remember, nothing should be done from the testis, not from the scrotum. So you do number 1 ultrasound, scrotal ultrasound. Number 2, CT abdomen to see the lymph node. Number 3, X-ray chest, and if you have PET scan, go for PET scan. And tumor marker. That's it. No biopsy, no FNAC. Tumor marker, alpha fetoprotein, never ever high in seminoma. If alpha fetoprotein is high, this is not seminoma or choriocarcinoma. So alpha fetoprotein is never high in seminoma or choriocarcinoma. It is mainly high in yolk sac tumor, but in other tumors also. Non-seminoma, it can be high, never in seminoma. Beta HCG is mainly for choriocarcinoma, but in 10% it can be high in seminoma. Why in 10% seminoma? Because it comes from syncytial trophoblast. 10% seminoma, they do have syncytial trophoblast, so it can be high in 10%. Yolk sac is AFP, but remember embryonal cell cancer 30%, teratoma 40%, so it can be high in other tumors as well, but yolk sac more than 90%. For seminoma, we order placental alkaline phosphatase, and LDH. These are the two markers for seminoma. LDH and placental alkaline phosphatase. So only tumor marker you order: CT abdomen, ultrasound scrotum, and PET scan or XHS. No biopsy, no FNAC. Do orchidectomy. After orchidectomy, the report will come. It is seminoma or non-seminoma. Then you treat accordingly. Okay. Now the last question. Carrel's patch and renal transplant is used for. Carrel's patch is used for A, B, C, D. Okay. So, देखो, yes, that's correct. A. देखो, the renal transplant is heterotropic. Heterotropic means a new position. And the anastomosis of the vessel is different in live and donor, and live in cadaver. So, this is the aorta. This is the vena cava. Kidney is placed in the pelvis. In live donor, the renal vein is anastomosed here, end to side, with external iliac vein or common iliac vein. So it's anastomosed end to side. But the artery, this is the artery, this external iliac, internal iliac is cut here. This end you ligate, and this end you take an anastomose here. So in live donor, renal artery anastomosis is end to end with internal iliac artery. But in cadaver, and vein is end to side. But in cadaver, this is the aorta and renal artery. I will not cut through the artery. I'll take a patch of aorta called Carrel's patch. So now I have taken the kidney along with the patch of the aorta. This is called Carrel's patch. The advantage is now I can anastomose this renal artery end to side along with the Carrel's patch. So Carrel's patch is used for cadaver renal artery anastomosis, where end to side anastomosis can be done. And remember, left kidney is preferred for transplant because it has a longer vein, longer renal vein. So this is a image showing the Carrel's patch here, a patch of aorta, and you can see this is a live anastomosis of the artery end to end, and vein end to side. But in cadaver, I can take the Carrel's patch here and do side to end to side. Alexis Carrel was the second surgeon who got Nobel Prize in 1912 for his surgery for vascular anastomosis. As I say very often, surgeons don't get Nobel Prize because it's not for technical advancement. The first surgeon who got Nobel Prize was Cocker's, Theodore Emile Cocker, in 1909 for his work on thyroid, and the second surgeon was Alexis Carrel in 1912 for his vascular surgery. So there's one more question. This is the live anastomosis end to end, and this is end to side with Carrel's patch. Now another question: Carrel's triangle is used for which anastomosis? And the options are ureter anastomosis, CBT anastomosis, bowel and vessel. Carrel's triangle is used for vessel anastomosis. That's a question. Remember, so you convert a round vessel into a triangle called Carrel's triangle, then you do the anastomosis. This is called Carrel's triangle. Now I will take 5 more minutes and I'll show you some X-rays and some IVPs and some CT. I mean radiological sign they do ask, about 10 radiological sign. This is the, no, this is not radiological, but a very commonly asked question, Fournier's gangrene. Last 5 years, I've seen 3 questions. So Fournier's gangrene is basically 3 words only. Synergistic gangrene. This is a combined aerobic and anaerobic. So this is a synergistic gangrene. Aerobic, no, not synergistic. Question 9, why not B? Question 9, I'll see later on. So, and aerobic, and testis is never involved. This is another very important point. Tunica albuginea acts as a barrier, which is why testes are never involved. So no orchidectomy should be done. Only you remove the necrotic tissue and give antibiotic. Okay. Now, fish hook deformity you get in retrocaval ureter. What is retrocaval ureter? The right ureter goes behind the kidney like this, So it forms a fish hook deformity. This is retrocaval ureter. So here, see here, ये जो यूं जा रहा है ना, ये है fish hook deformity. Because this is going behind the vena cava. This will go behind the vena cava like this. And it can only happen on the right side. On the left side we have aorta. We don't have vena cava. This is the maiden waist deformity. Yeah, Meet, it is a type of necrotizing fasciitis. It is a type. You can say it's a type of necrotizing fasciitis, like Melene ulcer, like other ulcer, diabetic ulcer. Here also it's. So the ureter, which normally go like this, at L5-S1 area, they get trapped in the fibrosis. So both the ureter come close to each other in this area. This is called retroperitoneal. See this? See the double J stent? Both ureter are close to each other. In this area, this is a DJ stent which you can see. So they have come close to each other. This is called maiden waist deformity. Primary retroperitoneal fibrosis is called Ormond's disease. Ormond's disease. Now, drooping lily sign. When you have two moiety on the same side and two ureter and two pelvis, then this will press the lower one and the lower one gets kind of pushed down. So this is called drooping lily sign, which you get in double moiety. Two kidneys on one side and rarely in nephroblastoma and rarely in neuroblastoma also. Neuroblastoma, drooping lily sign. Adder head here or cobra head sign, lower ureter, this is the bladder, lower ureter gets dilated into the bladder, inside the bladder, this is called uretrocele. So cobra head or adder head sign you get in uretrocele. Christmas tree or fir tree appearance of the bladder is a sign of neurogenic bladder. Neurogenic bladder. Hutch diverticulum, only one line. This is a diverticulum in the bladder, normally asymptomatic, looks like Mickey Mouse. Wigert-Meyer law, I'll tell you after this. This is a posterior urethral valve, only seen in males. Posterior valve. This is the bladder, this is the U is the urethra. Posterior urethra is dilated, only seen in male. And below the verumontanum there is a valve. So this is posterior valve PUV, giving keyhole sign on ultrasound. This is the bladder and this is the urethra, and this gives a keyhole sign. String of pearl appearance, I told you in obstruction intestine. This you also get in fibromuscular dysplasia, in angiography. So renal artery angiography may show string of pearl sign in fibromuscular dysplasia. This is a Staghorn calculus, very, very important. And we already know what forms Staghorn calculus: phosphate, triple phosphate, infected urine, alkaline urine, coffin-lid, crystals. And these are Staghorn calculus. How to differentiate Staghorn calculus? Angiomyolipoma? No, not related to. How to differentiate Stargardt calculus from the putty kidney? This is the kidney. These are the minor calyces. Stargardt calculus will be here. So it will have a shape of minor calyx and pelvis. Putty kidney will have a shape of kidney like this. So the black thing will be putty kidney. The blue thing will be Stargardt calculus, having a shape of. So if there's a sterile pyuria, and the calcification is in the shape of kidney, that is putty kidney, caseous necrosis. And this is another putty kidney. See the shape of the kidney here. Like here, this is the kidney. Stargardt calculus will be here, having a shape of the pelvis. And this is a, first one is putty kidney, second one is Stargardt calculus, and both are plain X-ray. Hydronephrosis, you get in IVP. So the dilated pelvis and minor calyx showing clubbing, this is hydronephrosis. Very different from Stargardt calculus. Compare this image, plus you can see the other kidney, you can see the ureter. This is IVP. And this is a Stargardt calculus here. You cannot confuse this with hydronephrosis. The kidney pelvis will be dilated and minor calyx will have clubbing. So this is hydronephrosis, this is Stargardt. And that's IVP. And Stargardt is plain X-ray. Putty kidney is non-functional, of course. Kidney doesn't function. So this is a hydronephrotic kidney. Of course, one cannot confuse this Stargardt calculus. So this is mainly seen in PUG obstruction or back pressure in VUR, etc. Now this is a horseshoe kidney. In CT, they do give the X-ray as CT or IVP, horseshoe. The isthmus is below the inferior mesenteric artery, and this is the flower vase sign of horseshoe. First one is normal, second is horseshoe. What's the difference? The inferior calyx is medially directed. Inferior calyx has gone inside. That's called flower vase sign, a feature of horseshoe kidney. This calyx normally is not there. This is only seen in horseshoe kidney flower vase sign. This is spider leg deformity in ADPK. Autosomal dominant kidney. What are the chromosome 16 and 4. And this is bouquet of flowers sign. Where do you get this? You get this as medullary sponge kidney. You can see from the minor calyx, bristles going like this. This is called bouquet of flowers sign. And this is the flame sign, extravasation from the bladder. This you see in extraperitoneal rupture of bladder, flame sign in cystogram. And this is the moth-eaten calyx in tuberculosis. The infundibulum is strictured, giving a moth-eaten appearance. And this is a champagne glass sign. This is the kidney. This is the ureter. When the cancer is in the ureter and you do RGP. What is RGP? Retrograde pylography. Inject a dye from below. तो यहाँ से डाई यूं जाकर के यहाँ पे ऐसे इकट्ठा हो जाती है. This is called champagne glass sign, where you get in TCC of ureter, transitional cell cancer of ureter. Okay, champagne glass sign. And that's it. Now I have forgotten. Someone had asked a question which I said I'll tell you at the end. I forgot what the question was. So you have to write the question again. I'll just wait for 2 minutes. I will give this to head office. Probably they'll upload the PDF. So can you write the question again, which I saw someone ask a question. I told you I'll tell you at the end. Then I have forgotten the question. So write the question again and I'll explain it. What about pancreatic fluid? No, that was from, yeah, Wigert-Meyer. Yes, correct. See, what is Wigert-Meyer law? Look at the screen, please. This is the, don't draw, just watch. This is a double moiety, 2 kidney on one side, 2 ureter on one side. So this is the upper kidney, black color, or let's use another color. This is the upper kidney, black, red, and this is the lower one, red. So there are 2 ureter, and there are 2 kidney. So I'm using red color for the upper ureter, and don't draw, just watch, and blue color for the lower ureter. Whenever you have 2 kidneys on one side, the upper moiety constitute 1/3, lower moiety constitute 2/3. So volume wise 1/3, 2/3. C-turn can cause sphincter damage if it is high type. It can cause, but normally rarely. So they go to bladder like this, but that is the wrong diagram I have drawn. What Wigert-Meyer law say? Wigert-Meyer law says when there are 2 moiety on one side and 2 ureter, they will always cross. So according to Wigert-Meyer law, the upper ureter will go like this and the lower ureter will go like this. This is what Wigert-Meyer law is. So in double ureter and double moiety, the ureter always cross. Now the second part, the lower moiety, this one, the red one will have ureterocele and the upper one will have vesico-ureteric reflux. So both moiety are, both kidneys can get damaged and patient can develop complete destruction of kidney. The lower ureter opening here will have ureterocele, causing back pressure and hydronephrosis, while upper ureter having VUR causing back pressure and hydronephrosis. So this is Wigert-Meyer law, where both ureter will always cross. The upper moiety will open inferomedially, the lower moiety will open superolaterally. The blue color is the lower ureter, but opening superolaterally having VUR, the upper ureter red color having inferomedial opening having ureterocele. This is Wigert-Meyer law. I am, well, देखो, pancreatic fluid collection is very common and it gets absorbed in acute pancreatitis. So we don't do anything. We wait for 4 weeks for the fluid to get absorbed. In case it gets infected, you can do percutaneous drainage under antibiotic protection. That was the question. After 4 weeks, it becomes a pseudocyst. If it persists for more than 6 weeks and size more than 6 centimeters, you can do cystogastrectomy. So that's it for today. And if you have any doubt, you can write. I'll wait for 5 minutes. Thank you, all of you, and all the best to all of you. Yeah, the ureter which is draining the upper kidney goes inferiorly, and ureter draining the lower kidney opens superiorly. This is, they cross, the ureter will cross. This is called Wigert-Meyer law. So I think that's it. I don't see any new question. Fissure management is sphincterotomy. Internal sphincterotomy. Lateral internal, cut the sphincter partially, called lateral internal sphincterotomy. You can cut the fissure also, fissurectomy, but that's optional. Fissurectomy is not the treatment. Treatment is lateral internal sphincterotomy. Okay? That's the treatment of fissure. Chalo, so all the best to all of you. Good night. Thank you.